So where do new treatments actually fit into these guidelines? Well, the guidelines really, because they focus on RCT evidence and only existing RCT evidence around reduction in CVD risk, you could argue that future trials that using novel therapies like PCSK9 inhibition that perhaps show a reduction in CVD events, that they would automatically fit in. But before we get those outcome trial data, there are going to be populations where we have phase 3 data where we do not have really existing treatments that are effective. So the FH patients, for example, who start often with very high levels, who despite statin therapy or despite combination therapy with other agents, don't get anywhere near the sort of targets that we would actually like. The current guidelines actually don't give you any real scope for the use of those agents. And really the only scope will be are those populations where you've demonstrated outcome data, which will take a great many years. So what do we do in the meantime? Well, actually we're doing really quite a disservice to our patients, because LDL cholesterol particularly is so intrinsically linked to atherosclerotic and cardiovascular disease. It is a causal factor. And if you basically believe it's a causal factor, not to measure it and not to consider it as a target for treatment, and look at treatments that potentially lower it by 50 to 70%, I think we're actually going to miss a trick here, and that over the next 3 to 4 years, as these treatments sort of emerge and we see populations where we have an unmet need, we won't actually be allowed to use these under the current guidelines, and that I think is a major disservice.